Connected Care Partnership is the Vanguard, so it's made up of two GP-led organisations, our Community Healthcare Trust, our local acute trust and our local mental health trust, but we do also fit inside both the Black Country STP footprint and the footprint for Birmingham Solihull. So we have quite a complex commissioning and provider framework in terms of how we look after our patients, which has led us over the last best part of 2 years to be doing quite a lot of work around how we bring together all our local providers, and we're looking after around 160,000 people in terms of the offer that we have for the Vanguard itself. But we believe that some of the things that we've developed are absolutely blueprints that you could take and put elsewhere in terms of how we, get our doctors involved and how we engage the primary care workforce. I'm pretty sure that we are also all familiar with the fact that primary care can probably tackle quite a lot of these things if it's done properly. But there is challenges in the workforce that we've got and how that workforce is deployed, and that we can probably look at better ways of doing that. And that's one of the things that we've had the opportunity to explore through the work that we've been doing on the Vanguard. One of the things that we identified through our programme overall as the Vanguard was how could we change primary care at the coalface. And we came up with a programme called Enhanced Primary Care. It's known within our teams as EPC. The idea being that we're taking that traditional MDT model and just shifting it and changing it a little bit and adding a little bit more competence, I suppose, to how we roll it out. So rather than just saying let's get a group of professionals that all work with that particular patient together, actually no, let's be a bit more structured about it. So the way we've looked at it through each of our practices to split practice teams into around 3,500 to 5,000 patients. This was based on the New Zealand model. Some of you guys might be familiar with that, where we're working in smaller cohorts of patients that are delivering care with people to fewer patients meant that you can have better continuity of care. We've got a variety of practices across our Birmingham footprint, ranging from a practice, in fact, a video we'll show you shortly, we'll talk about that, from about that 3,500 patient list size right up to 25,000 patients in a list size. So what we looked at was 3,500 being the smallest number that a patient group should be, and then where we've got practices that say have 8,000 patients, we split that into two teams. So the teams become completely responsible for their patient list within the practice. So that team is made up of GPs, nurses, receptionists, admin, and they're actually allocated to that group of patients. So it's quite a big piece of work that we went through in order to split lists down where you might have had 20,000 patients in a practice, grouping those people into those smaller groups, smaller clusters. But what we've found is the patients are seeing the right professionals first time, that the staff are really engaged by it. They feel like they're part of a team as opposed to being in a very large disparate practice where perhaps their practice team members don't talk to each other quite so much. And then recognising that this isn't just about changing primary care, it's also about looking at how we look at the overall both community care and secondary care and how that links into the sort of patient journey, so to speak. So we're looking at this here where you've got these groups of patients which would be 80% of the population that you probably don't see them that frequently. Your tonsillitis, your ear infections, those sort of things that don't perhaps come into practice so often, the well people. And then you've got your 20% of the most poorly people that need to probably fall into the 10,500 patient catchment, who are also being cared for by people that are outside of the immediate primary care provision. So that involves your mental health practitioners, your social workers, your district nurses, those people that are stepping in to look after more complex care patients. So that's how we looked at how we can maybe work this out from just being a primary care thing to actually being something that encompasses the overall delivery across the area. This is the process that we've gone through, and some of the things that we've identified as standard type additional resources into practices, the pharmacist role and the MSK practitioners who are your Enscope physiotherapists. We've also been upskilling our existing teams, so receptionist and call centre staff that we have are now trained in care navigation. So whilst we will always probably have patients that will say it's personal, I want to speak to, I don't want to tell you what the problem is, we are training our patients by the way when we speak to them that it's better that they share what their issue is so that we can make sure they get to the right person first time. And the fact that people are being looked after by smaller teams means that you can keep a tab on where problems are and where people have got issues. We've got quite a big spread, as you can see, across the Birmingham area. Birmingham obviously a very challenging healthcare area, high deprivation, high levels of migration, and extremes in health issues in terms of respiratory health, diabetic health, all those kinds of things are challenges for us, and we're working, like I said, very hard to see how we can meet those needs, primarily using primary care first. So in terms of the transformation of this, we've wanted to make sure this process has been led by our GPs, by our doctors, our nurses, the people that are delivering the care at the front line, because whilst our management team is very small and quite stripped back in terms of what we do in terms of the vanguard, we have got quite a lot of general practitioner sessions that are dedicated to management that mean that we can work up these sorts of models with clinical leadership at the front. And that's been absolutely critical to make this successful. Without those doctors and nurses and those teams getting involved, it just would be meaningless.
Hi, good afternoon everyone at Modernity. Name is Dr. Khan. I work at NQ Medical Practice. I've been asked to shed some light on EPC, that's so extended primary care. In simple words, I love it. I love the way the work has been distributed among the whole team. No more stress and strain. You're much more control of your whole day. Calling the patients when you want to, who you want to, depending upon if you have to see them or the rest. I'm very happy. It's revolutionized my way of working, and can't go back onto the old system anymore. EPS, wow.
So it's great to have somebody so enthusiastic, but I think one of the things that he's sort of alluding to is that actually what we've given back is quite a lot of control to the practitioners. So we obviously still see patients, but quite a lot of people are dealt with over the phone, and then you can work out in your day whether or not you need to bring that person in for 20 minutes, and we've been able to look at a situation where we've increased the time that patients are actually spending with doctors where it's more complex, because they've then not had to see those sore throats that actually just needed to have a prescription left at the counter because it was tonsillitis, or that person that then needed to be seen by a pharmacist instead. So actually the sort of streamlining of stuff means that the doctors are then just getting to see the most complex people. They've also introduced, as part of this process, it was an American model that's actually used by the military, and we've been testing that out, and again it's been a really, really productive way of getting the teams to work together, which is called Daily Huddle. These are stand-up meetings. They last for 10 minutes.
So the huddle process is based around our Team Steps ethos, which is evidence-based practice of communication, leadership, as well as mutual supporting and monitoring the situation to help our patients' care journeys.
Everybody's involved in the huddles, from the doctors to reception staff to the nurses, so we're all aware of patients that are of concern.
A lot of population, people coming from across seas, so it does enable each and every one to know and get to know their patients and how patients are and their issues and any concerns that patients have.
Huddles are done standing up. It's not a sit-down meeting. Any problems, doctors are very open to suggestions and
We find the huddles to be very beneficial for the staff to engage with the patients as well, also for the operational purposes of the general practice. Because for huddle, you can utilise a huddle to say if there are any staff shortages, so we can work better to distribute the workloads for clinicians and for admin reception team. So the huddles are beneficial for across the whole team. They're not only allocated for clinical or admin team. And then secondly, we use a huddle to discuss any patients of concern or any difficulties that the clinicians may have had on their sessions of that morning or that afternoon. So that everybody is aware of how we're going to handle that patient and the journey of that patient.
As a physician associate, I've had the opportunity to work at several general practices now, and St James's is the first place where we have used the huddle process. And for me, I think it's been brilliant as quite a newly qualified clinician. It's an excellent platform to use on a daily basis where every member of the team can voice any concerns and get advice from other team members on the day.
So the benefit for patients is that they have joined up care, they have continuity, and from a team perspective, we have got a shared vision of what's going on with our patients, and that helps us to coordinate their care better.
Team, really. One big team.
Every practice that's become EPC'd, so to speak, has then become inducted into how to do the huddling and how to go through that whole process and making sure they understand the benefits of it. It's not just, you know, let's just stand around and chat for 5 minutes. It's actually let's get the best that we can out of understanding where our complex patients are. You know, did something happen? And in theory, these meetings should happen whenever anything goes slightly wrong in the day, and that there is an opportunity to pull all the team together just for 10 minutes, just say, just had a bit of an incident, something's happened, and actually start dealing with that immediately, and as a group that they would actually, you know, work together to help each other. Seeing in terms of data is that the time that we've actually been able to sort of relieve in terms of GP time, you can see the number of sessions are quite significant, and we've brought on almost just over 5 new roles in terms of, you know, taking this forwards. Obviously some of this data is going to keep changing and growing over the period of this Vanguard till the end of the financial year. So anyone that's interested in this sort of thing, we can certainly share that and you know, make sure that you can see what you need to in terms of understanding the savings that can actually be made. I concur with the point that, you know, we need to put engagement at the priority in terms of making these sorts of changes, and, you know, we've taken the staff and the patients on the journey with us. I was at the staff engagement session for the group where Dr. Khan works, and one of their very established advanced nurse practitioners sat at the back of the staff engagement with us with her arms folded and said, "This is never going to work." And you know, naturally people don't like change. You know, we have to take people on that journey with us. But I did an interview with her for one of our protected learning time sessions, and her response 6 weeks after we put the changes into place was, "Please never change it back." Because for the first time ever at this practice, I have left for home on time. I am speaking to my colleagues. I feel like I work in a team. I understand who my patients are. She said it's a reason to come to work. And the step change in that was so significant. And it seems like such a small thing to change, actually, you know, just getting people to chunk down and work in smaller groups. I think the work behind that was quite significant, so I'm not belittling the actual nature of the work, because we, as I said, we've got certain practices that have high numbers of drug users, for example. You know, the importance of maintaining continuity of care for those particular patients absolutely critical. That when we went through splitting a list down, we went to very detailed, and we worked with GP to GP. This person's been your patient, they've always seen you, do you want to keep it that way? And working with them, and then liaising with the patients too, and actually saying, we're going to be changing the way that your practice works. You know, is that okay? And giving patients the chance to switch between the teams has also been a key part of this process. So that's essentially been our journey to date in terms of taking GPs on the engagement journey with the Vanguard. And I think because we recently, as an organisation, become a national organisation, we are also looking at where we've grown into areas like Hull and into Yorkshire, working with those practices too, to say, well, we've learnt this through the Vanguard. These are things that we've seen as opportunities for revolutionising the way that you work in general practice and making primary care really efficient. It's up to the partners in those areas to make those things happen, but we're working with them to look at elements of this that may or may not take off in other parts of the country. So for us, that's a really important thing in terms of getting that genuine spread, and that's a key part of the Vanguard process. The example I'm going to give is the Enki medical practice. So we basically said, right, we're going to have an orange team and a purple team, and we looked at obviously the staff that we got first to see how we could actually split that into two. In that particular model, they have got a GP, a partner on each team, a GP partner, and then there's a salaried GP, and then there's, at that practice, there's 2 nurses on each side, an ANP on each side, and 3 HCAs. So there's sort of a tiered team on each side, but it has varied practice to practice because it depends on what staff they've got there, and also depending on the list size. I think we have got a couple of practices where there's 1 GP sitting over the 2 teams, but the rest of the team's still split down. And it is about, you know, trying to work with what, because we're not going to say, oh well, you must have this standard list, because it's going to vary depending on what each practice list size needs. The way that we've done it in modality, it has been to employ these people on fixed term contracts. So we've employed them, and we're certainly with the pharmacists as well. We've sort of taken a balanced risk in essence, because it seems madness to suggest that you wouldn't employ these people, because they do an excellent job, and you know, very often you can see those lower back pain people wouldn't ever have to come across a GP's desk at all, you know. So I think whilst you're right that people are going to always say, well, could we employ somebody and say we're only going to be employing you for a year? But actually quite a lot of practitioners are prepared to take that risk to get that experience.